Uh, a very good afternoon to one and all gathered here, and I'm very thankful to State President, Secretary, and Tirupur IMA Branch President, Secretary, and Coordinator, all the members who participate here for giving the opportunity to discuss about the dermatological condition in this great platform. And I like to discuss today's topic is some interesting skin in summer. Just let me brush up what are the things discussed in this is like some basic thing like what is brush up of electromagnetic spectrum of sun, for what is photosensitivity and what is photodermatosis and what is the principles behind the photobiological things, and when we expose it to sun, what the direct effect, what is the immediate effect of sun exposure, what are the long-term effect, and how can drug can induce the photodermatosis, and what are the other conditions other than sun, some glands like a sweat gland, what are the related disorders during the summer, and how the infections can be aggravated or flare up during summer, and what are the photoaggravated dermatoses, that is other conditions which for those conditions summer or hot environment which trigger or precipitating the underlying conditions, and how we can prevent and manage these scenarios. The first, when we go to the electromagnetic spectrum, the wavelength of visible spectrum, we all know about around 400 to 760 nanometer. When we come in the lower spectrum of ultraviolet radiation, the band is divided into A, B, and C. The spectrum includes from 290 to 400. UVB and UVA is included. UVC is observed by the ozone layer. Only a part of a B, and 99% of UVA and only 1% of B reach the Earth's surface. Depending on the wavelength of ultraviolet radiation, either A or B, how it penetrates into the skin. Like UVB, whose wavelength is 280 to 320 nanometer, which penetrates up to the epidermal layer, and UVA, the wavelength is 320 to 400. In this 320 to 400, it is split into UVA1 and UVA2. UVA, since the wavelength is more, the penetration is more, it reaches up to the dermis. In UVA, it mostly affects the epidermal layer, so where we having the keratinocytes, melanocytes, Langerhans cells, all these cells play a role in the epidermal layer. So when the UV radiations, it touches the epidermis, these cells are affected. When the UVA, it reaches the dermis, mainly the fibroblast, we have the blood vessels, the connective tissue, all these things are affected with UVA radiation. Then when we come across the word of photosensitivity and photodermatosis, many times we will talk about photosensitivity. What is the photosensitivity? It is nothing but an abnormal response to ordinary light exposure. But photodermatosis is the condition where the heterogeneous condition of disorders resulting from abnormal cutaneous reactions to the solar radiation. It includes visible light, ultraviolet radiations, all in the spectrum. When we consider about the photodermatosis in India, what are the precipitating or potential factors? Because of the heat, sunshine in the most of the part of the country, and increasing population or overcrowd, humidity, cloudy environment, and the natural barriers like mountains, deserts, rivers, which reflects the ultraviolet radiations. And those, since India is an agriculture-based country, our farmers who are exposed in sun for a long time, outdoor fishing and other who are exposed most of that our traveling time, other working in the outdoor activities are more prone for the photodermatosis conditions. And during a summer, our kids are very interested and they'll be out of the small room and ready to play in the outdoor activities. So during a summer our kids are prone for photodermatosis conditions. Who are at risk? Mainly the skin type of 1. In India, actually, we are Indians and Asians are type 3 and type 4 skin type. more burns will be common in type 1, like a light fair skin individuals. When we expose it to the sunlight for more than 30 minutes to 1 hour, the risk is more. And the exposure time is around 11 a.m. to 12 p.m. The percentage of exposure is more than 50% of UV radiation is emitted during this period, which is more risk for the onset of the lesions. What is a photobiological principle? When we have the chromosomes which are present in the epidermal layers and dermal layers, when the radiation is fall on our skin, our chromophores will absorb the radiations. Once the ultraviolet radiation is absorbed, the electrons are moved to the higher level and it gets excited state. In the excited state, it can be in the single state or triplet state. Once the triplet state is formed, it produces photo products, that is step 3. Once photo product is produced, certain biochemical reaction will occur, followed by a cellular damage, and finally we'll get the clinical presentation. The clinical presentation can be an acute manifestation. On long term, when we are chronically exposed, that time we will have the chronic manifestations. Acute presentation will be in erythema, burns, and other conditions. And when we comes to the part of sun exposure, when we sun exposure, what are the conditions can be affected? The immediate effects like for sunburns, photosensitivity, phototoxicity, photoallergy, and polymorphic light eruptions. And when on pigmentary part, it can lead to tanning. That can be an immediate tanning or it can be delayed tanning. Long-term effect of sun exposure, we'll have the photoaging. Beyond the normal chronological aging, when we have chronic continuous exposure to sun for a long time, the dermal changes and all the dermal components are getting affected. It leads to early age of onset of aging. It can be a mild, moderate, and severe. That we'll discuss in later. And because of the sun exposure, we'll have the positive effect and also negative. One of the part is immunosuppression and photocarcinogenic properties also there. It can affect the melanocytes and non-melanocytes also. In melanocyte, it leads to malignant melanomas, and non-melanomas like squamous cell carcinoma and basal cell carcinoma. Precancerous conditions like actinic keratosis, seborrheic keratosis, all are flare-ups due to the continuous sun exposure. First, when we comes to the most common, one of the clinical presentation when we are seeing on our routine life is PMLE, that is polymorphic light eruption. This is because of the delayed reaction to ultraviolet radiation. The clinical lesions will be in the most common presentation will be patients will complaining of itching. The itchy lesion of variable morphology, either it can be in papules or plaque or even a vesicular lesions can be present mainly over the extremities, face and upper back and upper chest, uncovered areas. The characteristic feature is the appearance of the lesions. Patient can be explained that on after exposure to intense dose of sunlight, that is sudden exposure of light for a long period or for an hour or 1 hour, 1.5 hours like that. Usually it is more common in the first 3 decades of the life, up to 30 years, more common in female. And the skin types like from type 1 to type 4 are Indians. Type 3 and type 4, we are comes under that category. We are all more prone for PMLE lesions. Where geographical location of the areas like where high ultraviolet radiations are present, due to the continuous exposure, they'll get adapted to that. That effect is called hardening effect. In those individuals, the chance is less. Either we can able to appreciate here a well-defined erythematous plaque with the scalings. We can able to appreciate a multiple lesions over here over the face, and we can able to appreciate the same lesion over the other extremities. We can able to appreciate more common over the extensor is the most common side. Sometimes involvement of flexural is also common. Hands, this is papulovesicular, not only a papules, we can get a plaque type and papulovesicular type. The pathogenesis behind this, when we expose to the ultraviolet radiation, there will be an immune suppression. but sometimes they're resistant to UV-induced immunosuppression, which is normal physiological phenomena in a healthy individual, is missed here. And because of that, unmodified elements due to the UV radiations, which stimulate the immune response. The hardening effect is nothing but when a patient is continuously exposed to the sunlight frequently, they will start resisting to, they will start to adapt the changes. That is hardening effect. When we comes to the polymorphic light eruption, there is different types of varieties are there, like a papilla type. This is a more common when we see the patients, or when we see ourselves after sun exposure, we'll get a pink-coated papules mainly over the extremities. Papilla type, vesicular, eczematous, erythema multiforme type, and hemorrhagic type. Depending upon the severity of the exposure, the morphology can be varied. Then when we come up, across the term actinic prurigo, here the patient has an androgenetic pattern of hair loss. Since the density is very less, this site is more exposure to sun, and the same individual having the lesions over the extremities. Here when we see that the patient will have the persistent itching, and it will be a very severe when compared with other type of photodermatosis. Here the important thing is the continuous itching. The patient start to rubbing the lesion, which makes the lesion lichenified, and it will be the cycle will be continuous. The patient will scratch, and the cycle, vigorous cycle is continuously. So the lesions are very resistant to treatment. Here almost all the lesions like a papillonodular type. These type of lesions more common over here and extremities, and here because of thin hair. Then when we come across the word Hydroa Vacciniforme, this is mainly, here we can able to appreciate a very small vesicular lesions over the pinna. This is more common in the children because of intensive sunlight, UVA and B. Usually these lesions can be healed with scar or without scar. When the lesions heals with scar, it is called vacciniform, or if it is without scar, it is called Hydroa estivale. When in our routine life, at least one patient in 1 or 2 days, we will come across the word of urticaria. Urticaria is acute erythematous, edematous wheals can be appeared, and the lesions will be resolved within 24 hours. When we come across the word of urticaria, it can be multiple cause. It can be there. Some around 50% will be idiopathic. On that, one of a few endogenous causes and exogenous causes. In the category of physical urticaria, solar urticaria is one of the entity when the patient can develop the urticaria lesions following a sudden exposure to high intensity of ultraviolet radiation. With an exposure within a half an hour to 1 hour, they'll get the erythematous, edematous lesions over the exposed site. That comes under the category of solar urticaria. We can able to appreciate the erythematous lesion over here. When we comes across the word common routine word when we talk about is sunburns. Here it is like initially the more common over the extremities, exposed area. Initially the lesions will be in erythema, erythematous, edematous, and initially sometimes it can be in vesicular lesions, because once the vesicles forms, the intensity of the level affected is more, because it leads to the damage of the keratinocytes. On healing, there can be a despermation. We can able to appreciate a patch of paper, like peeling of paper over here. The other areas we can able to appreciate. Despermation and followed by healing can be either be hyperpigmented mostly. Usually the erythema, edema and vesicles heals with hyperpigmentation. Depending upon the radiation, the clinical presentation will be, if it is because of UVA, the erythema will be deep red and it will be start immediately and last for a few days. Because of B, it can be started after 3 to 5 hours and persist for a long. And photoaging, the accelerating the skin aging due to the chronic sun exposure, which is distinct from the normal chronological aging. Because of both UVA and UVB, it aggravates the skin aging. Mainly what happens, UV ultraviolet radiation A which has the wavelength of 320 to 400, deeply penetrates into the dermis, and dermis, it stimulates the matrix metalloproteinase, which causes the degeneration of the collagens, which can be, it leads to wrinkles. It can be a deep or fine wrinkles, and elastosis, which are damaging the elastins. We can able to appreciate here that deep wrinkles and yellow leathery appearance of the skin because of chronic sun exposure. Mainly in the elderly, we can able to appreciate. We can able to appreciate a typical pattern here is a rhomboidal shape, that is cutis rhomboidalis nuchae, which is more common in the elderly on chronic sun exposure. And when we see about the acute effect, and we have also long-term effect like photo, that is mainly of UVB and UVA. It can trigger some pre-malignant conditions like actinic keratosis, seborrheic keratosis, and all. And non-melanocytic skin cancers also triggered by chronic sun exposure like squamous cell carcinoma and basal cell carcinoma. And malignant melanoma also more common in the if they are exposure to high dose. Because of that improper repairing of UV-induced DNA and immunosuppression due to UV radiation, these carcinogenic conditions are common. When we come across that photodermatosis, the drugs can also, those who are taking certain drugs, when they are exposure to sun for a long time, exposure to drugs like mainly with the tetracycline groups, chrysopulvins, soralins, phenothiazines, all these. Sometimes what we using like a fragrance, all these can also have the phototoxicity. These are it comes under the category of drug-induced photodermatosis. When we all have the experience, if I out for some time, when we return back, we can able to appreciate the tanning effect. So what UV radiation in the role in the pigmentary disorders. So when we exposure to UV radiation, the uneven pigmentation and pigmentary disorder. So the major difference between the light skin individuals and dark skin individual is in light skin individual, the eumelanin content is less, and the melanosomes are a small aggregated distributed in only in the basal layer and first suprabasal layer. But in the case of dark individual, the high eumelanin content and the cells and the melanosomes are highly, it is very high content, and it is non-aggravated, clumsy, and it occupies throughout the epidermis even up to the stratum corneum. When we exposure to the radiation, UVA, it usually what it causes due to the photo-oxidation of already when there is a melanin in the melanosomes, it causes the photo-oxidation of pre-existing melanin, and these will be more prominent on the dark skin individuals who's having highly dense melanosomes and high eumelanin content already present in the dark skin individuals. And UVB induced tanning is less concerned for dark skin subjects. The dark skin populations are usually highly sensitive to UVA induced pigmentation. What are the pigmentary conditions which are triggered due to the sun exposure? What we come across is tanning. When we go for the outdoor activity or during summer, we'll go for the vacation, all these things will cause tanning. Then freckles. Where we come across the word of freckles, we will see the pictures later. Actinic keratosis, it will be a single adherent plaques. Melasma, it is a hyperpigmented condition, and solar light lesions. When we come to the point of tanning, there are three types we can be classified. Immediate pigment darkening, that is because of the photo-oxidation darkening of the already existing melanin and redistribution of the melanosomes into the dendrites. Usually, it will be an immediate and it will be last for 2 hours. Persistent pigment darkening, it will be persistent beyond 2 hours. Sometimes it can be extended even up to 1 week also. Then another is delayed tanning. This is because of the radiation, it stimulates the melanogenesis. It starts stimulating the melanin synthesis and increasing the melanin content in the melanosome, and it will be usually appear at the around 2 to 3 days later, and it will be last for a long time. If it is because of UVA, it will be appear 3 to 24 hours and it lasts for a day. If it is because of a bee, it will be appear around 72 hours and last for a long time. Okay. When we come to the term of melasma, almost in our routine life, we can able to see few patients with, it won't be a complaint for many of the individuals and will be a great concern for some individuals. The thing is, because everyone will have the some mates or in melasma like mangu vanduchina veetla kashtam vandrum, idella vandu patients, it will be on the patient's routine work. But according to us, once it comes, the recurrence, persistence, or it's a problem to us. When we consider melasma, there are two types we can be classified. Depending on the clinical type, it can be occupying only a malar area or a mandibular area or centrofacial. We can able to appreciate here like malar area. Here it is a centrofacial, even if it involve forehead also. When it comes to the how it will be spontaneously clearance for some individual, and how it is not cleared for persistent for a years together in some individual, because when it in the layer of epidermal or dermis or mixed, that is both epidermis and dermis, depending on that only the clearance and persistent of the lesion for a long period. For these individuals, during a summer or sun exposure will trigger the melasma. So the sun protection advice and doing the works indoor, avoiding persistent exposure to sun during the summer is very mandatory beyond the depigmenting. And freckles, it is a small multiple well-defined macules over the mostly over the face. Sometimes it can be over the extremities. This can be freckles usually fades during summer. But in the case of, freckles fades in winter, it flare ups in summer. Then we comes to the word milirial, that is like normal patient prodatumla vericolor. This is nothing but a milirial is a blockage of eccrine sweat duct, and at the level, what level the blockage is there, we can call as different terms. When it is in the layer of stratum corneum, it is called Milirial Crystalina. In the layer of mid epidermal, it is called Milirial RUBRA. Mid epidermal is the layer of, that is a prickle layer, spinous granulosum layer. So when the that obstruction in that layer, we call it as Milirial RUBRA or prickly heat. That is at the level of mid epidermal. In the case of dermoepidermal, it's called Milirial profunda. Another entity is there, that is pustulosa, where we'll have the pustule, but that is the sterile pustules. It is not an infective condition. It can occur either in the crystallina or rubra or profundus. We can able to appreciate a multiple clear fluid-filled lesions over the extremities. This is a case of Milirial Crystalina. This, where it is more common, is in the case of neonates, where the sweat gland and ducts are not completely formed, it is not matured. So during the initial few weeks of the life, it is more common for the Milirial Crystalina. And if that in adult, when it is common, means those who are admitted in the ICU setup and more occlusive, following an episode of high-grade fever, we can able to appreciate the multiple clear fluid-filled lesions over the occlusive areas. When we just rub that area, all the lesions will be ruptured on its own. And here we can able to appreciate some erythema when compared to the previous picture. Here it is completely a fluid-filled lesion, that's all. Here we can able to appreciate mainly the erythematous papules. This is at the obstruction is at the level of mid epidermal. This is called vercru, that is prickly heat. Called another name is called Milirial RUBRA, mainly over the occlusive areas. Here we can able to see the pustular lesion. This is called Milirial pustulosa. Sometimes when the sweat is persistent for a long time, the solutes deposited and it will stimulate it triggering the dermatitis condition changes. We can able to appreciate the extensive involvement of the trunk and upper chest. This is sweat-induced dermatitis. Not only all this, when we exposure to sun, we'll have some clinical pictures. And when the sweat glands are affected, we'll have some type of clinical patterns. Not only these things, some infective conditions which can also be aggravated or precipitated because of the sweat occlusive environment. One of the common thing is tinea versicolor. Because of the difference in the color, it can be present as a hypopigmented or hyperpigmented patches. With hypopigmented or hyperpigmented patches with a fine scaling mainly over the trunk. Main advice is we have to ask the patient to take twice bath, use cotton cloths, avoid the occlusive dressings during the summer. The important thing is tinea versicolor is not a contagious condition. Since we have the normal flora, the format is from the hyphae to non-hyphae form, it has changed. But the word of dermatophytosis and other thing, it is contagious. We have to educate the patient. But tinea versicolor, we have to educate the patient. Won't go for with it. We can control the thing, but it can have the recurrence. Another thing is the persistence of color for a long time, even after the control of the lesion. We can able to appreciate mainly over the flexural areas, the fungal infections, candida. These are intertriginous areas. We can get the fungal infections. And dermatophytosis, which is we can able to appreciate the well-defined lesions with the central clearing, mainly over the flexural areas and other. Depending on the site, we will mention as a Curis, Corporis, Pedis, Manum. Depending on the site, we can mention the tinea dermatophytosis condition. The important thing is because of over-the-counter, all the antifungals are available with the steroid combinations. Patients will get there by their own and they will apply the cream. Wonderful response will be with the clearance of the lesion for the initial few weeks because of along with the presence of the steroid. Once the patient stop, the real scenario comes back and all the lesions will start flare-upping. This is the major and big issues we encountered in our everyday routine thing. And one more thing, the patient will not happy with our treat, what we advise. Once you stop that, there will be a flare-up. Patient will not be happy with our advices. The important education to the patients to avoid over-counter applications have to be educated, and the hygienic aspect of isolated washing of the cloths, trimming of the nails, make the skin dry, avoid sharing of cloths. All the advices are very necessary, and the important is avoiding over-counter creams along with the combinations, mainly initially 2 combinations, triple combination, quatiderm, pentaderm is going on, keep on increasing nowadays. And another viral infections like the more common chickenpox. This is an adult with the chickenpox varicella. When the chickenpox comes under the age of pediatric, usually it will be resolved. We can give acyclovir, or we can, in the case of adult, the severity and complications are more. So when we come across the varicella in the adult, we should be very conscious. We have to inquire about all the complications, even a CNS meningitis. We saw few patients lost within 3 to 5 days after extensive involvement of varicella. Even we started acyclovir also. The complication rates are very high in the adult. And other viral exanthems are also common during the summer. Nowadays, the measles, rubella, and other things it comes reducing. Even yesterday, we attended a meeting. From the DPH side, they're mentioning about the fever with rashes. You just labeled and mentioned about their address because of screening of measles and rubella. They will take the serum and the swab. That the screening part is separately. Recently, they mentioned about the fever with rash. We have to mention the patient list to the DPH like that. When come across the herpes simplex, type 1 and type 2. Type 1 is more common over above the waist and type 2 is below the waist. We know below the waist sexually related thing, and herpes 1 is mainly above the waist. The thing is important is that once the immune suppression like a fever or even a sun exposure for a long time, the immunity is reduced. Mainly HSV1 will have the recurrence, keep on recurring. When the patient have a 2 to 3 days of roaming in the sun or outdoor activity, those have the previous herpes, history of recurrence will be very common. Fever, any stressful events, all this makes the immune suppression, causing the latent virus to come up and presentation. We can able to appreciate the grouped vesicular lesions over the lip. The thing is, if it is more, keep on like more than 5 or 6 episodes in a year, we have to go for the suppressive therapy for this herpes simplex. When the patient is symptomatic, they will give the shedding of the virus is more. When the patient in the asymptomatic condition, the shedding of the virus is very less. Then certain conditions where the real pathogenesis is different, but there will be a flare-upping of the condition due to the sun exposure is common. That among that is connective tissue disorders like the systemic lupus erythematosus, dermatomyositis, lymphocytic infiltration of Jesnus, and coming to the papilloscomus disorders like psoriasis, PITYRIASIS, RUBRA, PILARIS, and the inflammatory dermatosis conditions like atopic dermatitis, seborrheic dermatitis. All these conditions can be flare up. Even acne, rosacea, all these conditions can be flare up due to the sun exposure. You can see few pictures to enlighten that these conditions we should not miss easily. Few pictures we added. This is a patient with extensive involvement of erythematous, scaly lesions of very fine scales from head to foot. She have the lesions, oral lesions, or we can able to appreciate the oral lesions. She is the case of systemic lupus erythematosus. In these conditions, not only the skin internal organs, all the involvement, lupus nephritis, and other involvements are there. For these patients, photoprotection is very mandatory to reduce their frequent flare-up of the conditions. Whatever the underlying treatment modalities of immunosuppressant, either on oral steroids or immunomodulating agents or in a pulse therapy, the patient education regarding certain flare-up of the education must. In that, photoprotection is very must in the case of lupus erythematosus, either in the case of discoidal or systemic LE. We can see the extensive involvement, even a skin necrosis over this area. This is a patient of rosacea. We can able to, it's not that much prominent. We can able to appreciate the erythematous lesions over the nose. This is a case of rosacea, which is flare up during sun exposure. In many types are there, telangiectatic type, pustular type. The more thing is when they are exposure to sun, the flare up, the erythema is more. We can able to appreciate phytophotodermatitis, that is many many substances when we are exposing to the outside plants and exposure to sun, lesions of phytophotodermatitis also form. This is a case of Darier disease, that is one type of genetic disorders along with autosomal dominant, affected mainly in the calcium. The thing is, it is the important differential you think of it is Intertrigo, like other fungal infection. But when we examine the other side, we can able to appreciate the hyperkeratotic papules. So some lesions will mimic same. For these lesions, we need topical steroids. But in the case of Intertrigo, we should not use topical steroids. So sometimes the morphology is almost same. The diagnosis part is the challenging. Either we have to take the topical steroids or other part. That is the challenging thing. Here it is like when we see like a previous fungal infection type of picture, we can able to see the border. But this is the condition of papilloscomus disorder, where it is here, it is not an infective condition. It is a part of papilloscomus disorder. The kernization process is affected. Mainly here, islands of normal skin will be there. There won't be that much of erythema won't be there. Erythema as like in fungal infection, central clearing. Here won't be a central clearing. Even the border lesion is there. There is not clearing. The erythematous scaly lesions are present. These patients will have the lesions in the palms and scalp. And this is the common cases where we encountered in our routine. Even the name itself scary to the patients, psoriasis. When we mention the word psoriasis in English, the patient will get panic. When we use the same name in Tamil, the patient will be happy. Because they're not aware of the psoriasis, the word it is known to everyone and make them scary by medias and neighbors and all other individuals. Usually psoriatic lesion, this is a papillosquamous disorder where the keratinization process is affected, more scalings will be there. It will be looking very scary, but it is not contagious. Depends on the severities, the treatment modalities will vary. Usually the psoriasis lesions will be more in winter and summer it will be settled. But in few individuals, it will be vice versa, flare up in summer. Whatever we come across right now, we saw some conditions direct effect, some sweat gland related, some infections, some photoaggravated conditions. Overall, what happens is overall the skin metabolism is affected, and we have some freckles, pigmentary changes, dermal collagen affected, it leads to wrinkles and other thing. The moisturizing effects of the skin is lost, and other cellular and biochemical changes also encountered. And we have the biggest effect of carcinogenic effect also from the sun exposure is there. So what are the gods or natural gift to us to protect from us is the thick epidermis, natural antioxidant, what we take in the food, and other natural UV absorber which is present in our thing is melanin and uracanic acid, and natural DNA repair mechanism. When it fails, we end up in malignancy, and fast ligand signaling, all these having the natural protection to our skin from this UV radiation. And how we can prevent and manage? During summer, we need adequate hydration and avoiding a prolonged exposure to the sunlight and using a good spectrum of sunscreens. The important thing is when we want to apply the sunscreen, how it is effective. Whenever we are applying the sunscreen, we should not apply only a patchy area or like that. A complete coverage of the face and extremities. If it is exposure side, we can apply to the extremities, upper chest and neck area. And we should apply the sunscreen half an hour before sun exposure. Even now, water resistant sunscreens are there. When we exposure to even a swimming pool or anything, that time also we have the chance of tanning. So applying sunscreen is ideal. One more thing, like wearing a protective cloth and hydration of adequate hydration during the summer. All these, it can prevent our photodermatoses, and knowledge related with other condition also will help for us to prevent from the triggering thing. And when it comes to the management, the main thing is, if it is a mild, we can educate the patient, and whatever thing, the counseling part of the patient is very important. How it causes, what are the things. Then for a mild cases, we can give the soothing agents. If it is moderate, we can use a topical steroid. The topical steroid is like a double-edged knife. We want to make sure either it is a non-infective, either steroid will flare up or it will give a good response. All these things we have come to the proper diagnosis. And oral antihistamines make the patient comfortable, not to scratch. Let them comfortable. Once they are not scratching, sometimes the flare up of the lesion will also settle down. And in the case of very extensive severe, that time we need an oral, some immunomodulating agents and short course of steroid also needed. What I discussed is a part of dermatology. It is like we touched it here and there. We may miss some part. Whatever queries we can discuss in a next session also. In this session also we can, if we missed anything, we can do in the future sessions. Thank you.